Welcome to the Diabetes Podcast, where real stories meet real science, helping you take charge, not just take medicine. Sliding scale insulin. It's one of the most common regimens used in type 2 diabetes, and one of the most frustrating. In this episode, we share what's really happening when blood sugars keep chasing the highs, why insulin timing matters more than most people realize, and how small shifts in dosing strategy can create life-changing control. You'll learn what over-basalization means and why it keeps A1C high even when the fasting glucose looks perfect. You'll learn the key difference between basal and bolus insulin and how to move from reactive sliding scale dosing to a proactive, personalized plan that fits your real life. Whether you're newly diagnosed or you've been using insulin for years, this episode will help you understand how to use insulin intentionally so you can feel confident, steady, and in control. Let's go. Hello and welcome to the Diabetes Podcast. I'm Richie.
I'm Amber.
And Amber, before we get started, I would like to let the audience know that if they have not yet subscribed to the podcast, to please do that. It really helps to get this podcast out to the approximately 46 million Americans that need to know that there is hope in defeating this disease. Additionally, if any of the listeners are interested in a weekly email with bulleted summaries of the podcast, they can sign up for our new newsletter, and I'll have the link to the sign up in the show notes below. And now, without further ado, let's talk about all things insulin, specifically sliding scale insulin. Amber, one of the biggest things I hear from people with diabetes is, I always feel like I'm chasing my sugar. They take the insulin and their blood sugars still spike, and the doctor adds more, and this kind of snowball effect of I'm going to not just have to continue taking medicine, but I'm going to have to take increasingly more medicine. How does how does this work? Tell us about sliding scale insulin. Something I'm going to go with a little bit of a throwback. Something that I know nothing about.
Yeah, so I wouldn't expect you to know much about it because you don't take insulin, and you wouldn't be unlike most of the people that I see daily who knew absolutely nothing about sliding scale until they had to take it. And it's interesting because you get this sheet of paper from your doctor, sometimes leaving the hospital, and it'll say something like, if your blood sugar is between 150 and 200, take 1 unit. If it's 201 to 250, take 2 units. 251 to 300, take 3 units. And then some people have like a low dose sliding scale, a medium dose sliding scale, a high dose sliding scale. And of course, the high dose would be for someone who is more insulin resistant, somebody with type 2. So you have these different scales, and the biggest thing about it is people are always chasing the blood sugar because the sliding scale is designed to take care of the sugar in that moment. It is taking care of what has already happened in the past and not what's going to happen in the future, because most of the time sliding scales are instructed to be given before the meal. And if you eat carbohydrates in a meal, the sugar is going to rise. So you're not really giving insulin for what's about to occur. So people are always playing catch up. They're following the scale, checking their sugar, reacting to the number, and just really still frustrated.
Okay, so this is a reactive protocol, not a proactive protocol.
Exactly. Yeah. Okay. It's very reactionary, and that's exactly why it fails so many people. An example would be if somebody was about to eat supper, let's say, and their blood sugar was 90. 90 doesn't fall into that 151 to 200 frame where they would take insulin. But you and I both know if you have carbohydrate intake from your food, the blood sugar will rise. So they end up not taking insulin from their scale, eat mashed potatoes with gravy and chicken breasts, or, in a roll, what have you. So they've eaten about 60 grams of carbohydrates, give or take.
Hmm.
And there's no insulin in their system really to cover the sugar from the high blood sugar. There's no insulin there to take. And so they're high all night long. Most of the time, they're on too much baseline insulin, and we'll describe what that is later, but they kind of like fly down during the night, wake up at a good number. That's sometimes the story. There's all kinds of different stories with insulin. But yeah,
So,
you're just too late.
and again, I'm kind of new to the insulin game. Like, why isn't this effective? Because it sounds to me like if you're doing what you're supposed to do and you're
Oh,
accurately, if
supposed
you're,
to, my favorite
well,
word.
okay, but if you're doing what you're supposed to do and
Right, what you've been
you're
instructed,
accurately
what your
counting the
prescription
carbs, and
says.
I'm referencing it to the scale that is appropriate for the type of insulin that I'm on. I mean, like, why even make the scale if it's not going to be effective?
Well, the scale is kind of outdated and it's
Hmm.
not really recommended as the best thing to do anymore, but it is something.
Hmm.
It is relatively safe because you're covering the paths, so it's a little harder to give too much. Of course, you can, it's insulin. That's why a lot of people have gravitated more to a set dose or a set dose plus a scale.
Hmm.
There's a lot to it, and it's very simple, but at the same time very confusing. So here's another example. There's something called a correction factor, which is essentially also called a sensitivity factor, and it is how you respond to like 1 unit of insulin will lower your blood glucose levels or your blood sugar levels by X amount of blood sugar points on a finger stick monitor or on a continuous glucose monitor. So
Hmm.
if your sensitivity factor was, let's say, 40, so
Right.
meaning 1 unit of insulin will lower your blood sugar 40 points. If your blood sugar was 350, so I'm do some quick math. If it's 350, but you want it to be, say, 100 as a fasting level, it needs to come down 250 blood sugar points. So you would need about 6 units of insulin to get you down to that. But if you were on a sliding scale that was like one for every 50, let's say,
Hmm.
and I said the blood sugar was 350, and you did that, you would take 5 units. So it wouldn't quite be enough to get you to the point where you want to be. And the reverse is true. If you were even more sensitive, let's say 1 unit of insulin drops your blood sugar by 80 points, but you're on a sliding scale that's, in increments of 50, the higher your blood sugar, the more your risk of having a low blood sugar. And people just kind of really ride the roller coaster. They crash and fly up because they treat the low and the blood sugars go too high and they take more insulin and crash. And it's it's kind of like this insulin rat race.
So, as you're saying this, again, I'm a visual learner. In my mind, I see Zach Galifianakis in a meme where he's got all the numbers and everything coming at him,
Yes, I've seen
and
that.
my eyes are just kind of rolling back. This is something that I'm supposed to do before every single meal.
Yeah. Well, the recommendation is to take it before meals, but you bring up such a good point because so many people in the example before, if the blood sugar was 90 before the meal and they didn't take any insulin and then had, say, 60 grams of carbs and then the blood sugar is 390,
Right.
they don't want to go to bed with a blood sugar of 390, so they follow their scale and give, let's say 4 to 8, 10 maybe units of insulin. And most people have more basal insulin than is truly baseline. So we'll talk about basal versus bolus insulin in a minute. But the basal insulin, just if somebody's already on this would be the Lantus, Toujeo, Tresiba type insulin. That's been bumped up to cover and get the fasting in place, and also to kind of cover some mealtime insulin. So people fly down from too much basal insulin overnight, and on top of that, they have this huge dose from the scale that should have been before the meal,
Hmm.
and it just compounds to having a crash in the middle of the night. A lot of people who take insulin are known to get up in the middle of the night and eat. So that's something I learned as an educator, to ask people, like, are you ever getting up in the middle of the night to eat? And I think it's very disproportionate, the number of people who take insulin and have type 2 who get up in the middle of the night and eat versus the general population.
This sounds exhausting. This
Which part of it?
like
Yeah,
no,
right?
I'm just letting you know we do this every week. This one's particularly tough for me. This is golly, this is hard. I'm getting a lot of empathy for the struggle. The struggle
The struggle is
is
real.
truly real. Yeah.
Absolutely. And anyone that has experienced this is like, yes, yes, yes. Oh, so okay. I think based on what we talked about so far, we definitely have to um, break down the different types of insulin, like these two words that I've thrown out so far,
Okay.
basal
Yep.
and bolus.
Hmm.
Because I don't think you knew like what in the world I was talking about when I said
Well,
that.
I mean, again, I cannot have been married to you as long as I have and not heard the words, but I would not be able to accurately explain them to anybody. So for the newly diagnosed or newly prescribed folks in our audience who are just now getting on insulin, can you give us the Cliff Notes version of everything you need to know about basal and bolus insulin?
Yes, and I'll also say it's not for the newly diagnosed or anything like that. I have talked to, I would say the majority of people that I talk to, even people who have type 1 diabetes, who have, just like you, they're like, I've been to endocrine offices, my doctors have used these words, basal and bolus, and they might have some vague understanding of what they are, but really could definitely not do a teach back, like couldn't explain what they are and when they're used in many circumstances. So it's not just for someone not on insulin or newly diagnosed. A lot of people don't know this. So I'll try to keep it
Hmm.
simple. So think of insulin in two main jobs that it has to do. So remember, insulin is the key that unlocks the door to the body's cell and lets
Right?
the glucose from the carbohydrate containing foods that you eat get inside the cell. So the basal insulin is, I like to use basal that starts with the letters BA. So it's spelled BASAL. BA is
Hmm.
also basal, background, basic needs for insulin, the baseline. It's the idle engine that keeps the glucose steady in between meals and overnight.
I,
So it's only meant to cover basics.
I have
Yeah.
a question.
Uh-huh.
So in a normally functioning pancreas, is it releasing kind of the same thing? Is there a basic level of insulin that a fully functioning pancreas is releasing all the time? Is that
Absolutely.
okay?
Absolutely. So our bodies are always repairing and rebuilding and taking care of things. So we need fuel in the engine at all times.
Hmm.
Whether that fuel is coming from muscles, whether it's coming from stored glucose in the liver,
Hmm.
wherever if it's coming from food that we've just ingested. So the doors to the cell need to be open to let glucose get in at all times. So yes, the idea of taking exogenous, so exogenous just means you're injecting it, it's coming from the outside.
I got to add it to the system. Yeah.
Yep. The idea of taking exogenous insulin, so adding it in through a shot, you want to match normal physiology. You want to match what the pancreas would do if it could.
Hmm.
If you didn't have insulin resistance, if you did have all the functioning pancreatic beta cells, you want to replace what's missing or give it a leg up, if you will. Because a lot of people with type 2 produce even more insulin than you and me because they're trying to overcome the resistance.
So I got maybe a more technical question.
Shoot.
If there is a normal kind of baseline level of insulin that's supposed to be distributed throughout my body, how do I do that with like just a shot? That seems like it's always going to be like this big spike and then
Oh,
another
good
big spike.
question.
I'm not
Yeah.
going to give myself 30,000
Mm-hmm.
shots a day.
Mm-hmm. That's why you have two different types of insulin in general. There's
Okay.
actually other types, but like as insulins have progressed throughout time, they are adapted to mimic normal physiology better. So
So is it
your
like a slow
long,
release then or something? Is that how
yep,
that works? Okay.
yep. So your long-acting insulin gets injected into fat, and it works to have an enzyme release a little bit of insulin pretty steadily for about 24 hours. So it's
Okay.
meant to cover in the background for 24 hours. And then your bolus insulin, so that word bolus, think of a bowl. Remember, it
Hmm.
starts with the letters B-O, bolus. Bolus is just like more at one time. Um, as a dietitian by trade, I think of a bolus of food. It's that gummy food product that you chewed up and then that you swallow. You swallow a
Hmm.
bolus of food. In the hospital setting, they might give you a bolus of a certain mineral that's missing to try to
Hmm.
regulate, like calcium in your blood, for example, different potassium, different things. So a bolus would be like one of those little hanging bags that you would get in the hospital. A bolus just means more at one time. So to help remember it, you can think of a bowl of food.
Hmm.
You might eat food from a bowl, or you could also think of it as bonus insulin. So it's the insulin on top of the basal. It's your mealtime insulin. It covers the carbs you eat, and it also corrects high blood sugars because maybe the basal isn't lining up. You could have stress, cortisol, different things that get released. That there's like 42 different factors that affect blood sugar. Just the fact that you have diabetes, sugars can do what they're going to do.
And
Sugar's going to sugar. No.
just check on learning. So I'm going to take the bolus before I eat the food and in proportion to the, or at least matched to the amount of carbohydrates I'm having in that particular meal. Is that right?
Ideally, yes. So
Okay.
you've got your basal insulin that works slowly and steadily, and it lasts all day long. And then you have the bolus insulin that acts quickly and burns out pretty quickly as well. So you need both of these insulins for the full picture of covering what normal physiology would be. So the basal is going to hold you steady when you're not eating. And like you said, bolus tackles the rise from food. And in the US, the most common bolus insulins, so bowl of
Hmm.
food, bonus, would be your Novolog and Humalog. These are the what we would call a rapid acting analog insulin.
Hmm.
And then there's also newer to the market Fiasp and Lumjev, which a couple of people are on, but much less so. They are ultra fast and they tend to be really good for people who dose right as they start eating, which is kind of most people in my experience. And then for the long acting basal baseline basic needs and the background insulin, most people use Lantus, Toujeo, or Tresiba, and those last about 24 hours or more.
Okay.
So,
So if I
mhm.
again check on learning, make sure I'm getting it. Um, so I have to have both, and the two of them together kind of mimics the insulin release that a normal pancreas kind of just does automatically. Is that is that
Yes.
okay?
Yeah, very good. And I think the biggest misunderstanding in what you just said in the combination of these is timing. So
Hmm.
people will often inject right when the food gets to the table, or even like 5 to 15, 20 minutes, half an hour after they've started eating. And then they will spike really fast and have the blood sugar that was beautiful before the meal, 90 to 110. And then all of a sudden it's 260, 280.
Mm-hmm.
So oftentimes that's what triggers people to remember to take their insulin because they're like, oh no, I forgot. And the sugar's
Right.
280. So a common type 1 mistake is that then they will give insulin by way of their carb to insulin ratio. So, like, let's say they had a 1 to 6, meaning they need 1 unit of insulin. I'm sorry, a 1 to 10, let's go with, because math. So, say they have a 1 to 10 ratio and they have 45 grams of carbs. So when you're just doing insulin pens, the question is, do I give 4 or do I give 5? Because it's 4.5 and the
Right.
insulins, and unless you have the half unit dosing, most people don't that are adults, they would be safer to choose the 4. But some people are like, well, I know typically when I eat that, that's a 5. And a lot of people with type 1 no longer, like they might have started out with a carb to insulin ratio, but then they start looking at food as that's a 6, that's an 8, that's a 10. And sometimes it works really well for them, and other times it doesn't because they might have really not been thinking about their correction factor in the
Mm-hmm.
midst of all that. So it's a lot of decision making, and a lot of people get decision fatigue about how much insulin to give for that. But I would say the biggest thing is people forget. They don't know what they're going to eat. If you're eating out at a restaurant, they don't know when they order the food versus when it arrives. And a lot of people who give injections will excuse themselves from the table to go to the restroom to give the injection before they come back. And there's just a lot of timing issues around that. So, yeah.
So I got a question regarding that. Like this sounds like just a planning nightmare,
Yeah,
really. I mean,
you would be correct. And
like,
it's all the
like
it's a
I,
common thing.
like if you're eating out,
Mhm.
like I don't know, like I'm nowadays, at least where we're at, it's pretty common to see the caloric values for the menu items that you're ordering, but as far as how much of that is carbohydrates, much less like,
Yeah.
sugars and all the other kind of stuff, like I have not seen that readily available anywhere. So unless I'm just doing a lot of research on the front end, or unless I'm getting like very, very good at knowing the, let's just call it, macronutrient composition of all of the foods,
Yeah.
everything that I might possibly be putting into my mouth. This, I don't know how you do this well.
Most people don't. That's
Hmm.
exactly that's exactly what happens is, other than like a very general, I can't have rice because it spikes my sugar too high, or I can't have pasta, it spikes my sugar too high. I don't eat breads, other than like very general things that people notice,
Hmm.
they the understanding, like I can't tell you how many times I've talked about mealtime insulin dosing with people and they're like, well, what about chicken? Where's the chicken on the carb list? Where's the eggs? And like
Right.
those are protein, or that's protein and fat. So protein and fat are not carbohydrates. And it's really a confusing point for people, to the point where people just throw their hands up. They're like, well, I'll just avoid these two things, pasta and rice, because I know every time I have them it's just out of control and it's not worth it. But everything else that contains carbohydrates is somehow okay. But and it is, let's be very clear. You can have pasta, you can have rice, but a lot of the reasons why pasta and rice are demonized, if you will, is that 1 cup of, let's say, um, corn, 1 cup of that
Hmm.
is 30 grams of carbs. 1 cup of mashed potatoes, 30 grams of carbs. A cup of fruit, 18 grams of carbs. But then when you have a cup of rice or pasta, that's 45 grams of carbs. So for that same volume, you're going to see a
Hmm.
much higher rise in insulin. And, heaven help you if you do um, some takeout where the whole container's full of rice, then you've got like three
Yeah.
cups of rice. Do the math on that, 45 times 3, you got 135 grams of carbs, which is like half of your total carb needs in that one, which means you would need half of your total bolus insulin needs for the day there. But people are afraid to take, if they're usually taking like 3 or 4 units, it's hard for them mentally to get their head around taking 8 units. They're like, no, I'm going to crash. And they have every right to be cautious. It's insulin.
Yeah.
Um, it is a lot. No two ways around it, and it can be very frustrating for many, many people.
Well,
Um,
I think
yeah,
not just that. I mean, you also talked about like the sensitivity scale. Like, how do you, other than like
yeah. How do you
trial and
know?
error, how do you
Hmm.
know?
Right. Typically, insulin is weight based. So okay, full. I know we do a disclaimer for every show, but I just kind of have to do it here again because insulin is a prescribed medication. One should not just change their insulin dose like, oh, I heard the diabetes podcast, so now I'm doing this differently. Please talk to your doctor,
Hmm.
endocrinologist, have a conversation before changing any of your insulin or doing anything differently. This is not medical advice. This is information for you to have discussions with your healthcare provider about. It's not for you to take and go cowabunga, so just it's for learning purposes. So typically, if someone's starting insulin, it'd be at about 10 units a day or somewhere. It's usually about 0.15 units of insulin per kilogram. So, but anywhere from zero point 0.1 to zero point 0.2 units per kilogram of body weight. And then you would titrate up by about 10% every few days if the fasting blood sugars, which is fasting is the first thing in the morning, almost before you even get out of bed, because there's something called dawn phenomenon where the hormones kick in and can raise sugars right when you get out of bed. Um, but but usually people start there, and it's pretty normal for people to be on a lot of basal insulin, getting that fasting level under control, because some days it'll be under control and some days it'll be high. So the doctor will have you keep titrating it up until sometimes the basal is 60% or 70% of the total daily insulin, because a big problem in type 2 is the liver still continuing to put out sugar to because of the insulin resistance that's there. It just builds up, so you've got these really high fasting blood sugar
Hmm.
levels at all times. um, but the problem occurs when people get past about a half a unit of
Hmm.
insulin per kilogram of body weight. Then we get into this area of over basalization.
So I'm not quite understanding over basalization. Can you explain that a little bit?
Yeah, so that's when someone keeps increasing their long-acting insulin shot. That would be the Lantus, Toujeo, Tresiba, that basal insulin, even though the fasting numbers look great. So the fasting numbers could be, 100, 110, 115 sometimes, and but the A1C is still 8.5, 8.7. So when they see the physician, due to the fact that giving more shots is a more complicated regimen, they
Hmm.
increase the basal even further. And it's also another copay for a different type of insulin. So it just tends to happen where people get on too much basal insulin. So basal insulin is really just meant to manage the fasting glucose. And then when you use too much, it starts covering for what's really a mealtime problem. So I'm not meaning to put all this on the physician, because it's not. Because if
Right.
you're taking 80 units of a basal insulin shot, what is 5 units of a rapid acting. It's like a drop in the bucket. And so people are like, that one doesn't really work. I can't tell you how many times somebody have said that insulin doesn't even work, and it's really just a dosing issue. Like if you got $80 every day, and one day I came and gave you $5, you'd be like, give me my $80. It's what is that compared to the other? Because it's really like unit to unit.
So if I understand correctly, the increase in the basal is really trying to get you through the night, I guess, because if I take the basal first thing in the morning, it's regardless of how it's releasing, it's going to start tapering out towards the next morning. Is that the idea?
Well, I mean, people take their basal insulin at bedtime, um, because of an insulin called Levemir that did need to be injected. Levemir didn't quite last 24 hours, and that's off the market in the United States now. But because that used to be like it would only work anywhere from 12 to 18 hours, they started kind of splitting the dose of basal insulin.
Okay.
Another reason why people would split the dose is because people would tend to forget their insulin. So at least if they split the dose, it was
They got
less of,
half of it, right?
yeah, at least they got half of it. So there's a couple of things about that. But no, the long acting insulins on the market now last 24 hours, sometimes even longer. But part of what you said was right. The long acting insulin is really meant to cover down overnight while people are sleeping, and then in between the bolus or rapid acting insulin that's given before meals.
Right.
Yeah. So once you're on 60, 70, 80 units of insulin, but the A1C isn't budging, like the fasting is perfect, but the daytime numbers are spiking up high, that is the key. That is the sign. It's time to add some mealtime dosing of insulin, not more basal. And sometimes the basal needs to be cut back a little because you had too much of it,
Right.
to allow the space for more mealtime insulin.
So rather than just a blanket big dose of basal, a more effective strategy is to be more accurate or more strategic with the administration of the bolus. Is that correct?
Yes, and the
Okay.
reason is because if you did it that way, you're matching normal physiology better. You're matching what your pancreas would do in the way that it would do it better. So once you hit that tipping point where the A1C is still not under control, that's the red flag. You need to add more rapid acting insulin.
Okay. All right.
So, yeah,
Let's take it on a slightly different tangent.
a different tangent. Okay.
Well, I mean, I don't think we're going to achieve mastery in one episode,
No, you're right.
there's a
Fair,
lot to
because
cover.
that was a lot of information, and not all of it is for all people.
So speaking of
Mm-hmm.
all people, how soon do most people with type 2 even start insulin? I would imagine
Ooh,
that
good
you're going to be
question.
diagnosed. So just from what I know so far, the diagnosis of type 2 diabetes occurs at approximately 50% beta cell loss or somewhere
Mm-hmm.
thereabouts. So that
Mm-hmm.
says I am still producing some insulin.
Yeah.
And I would guess that I'm probably not getting prescribed until much further along, would be my
Yeah.
guess.
Yeah. The truth is, most people are prescribed insulin way too late in the game.
Hmm.
There, there's plenty of evidence to support early insulin intervention. We spoke a little bit in, I think it was the last podcast, about why early insulin intervention doesn't occur. And I'm sure if you're
Yeah.
listening right now, you can totally understand why early insulin intervention doesn't occur. Because insulin brings with it a whole new layer, or
Yeah.
layers, plural, of
I
complication.
can't even imagine going from
Absolutely. Yeah.
zero to accurately administrating both basal and bolus
Yeah.
overnight. No way that gets rolled out
Yeah.
well.
That's why most people start with basal. But yeah, if you have LADA or you have type 1, um, diabetes, you really need to be starting with
Yeah,
both.
sooner than later, right?
Yeah, and even people with type 2 need to typically be started sooner than they are, because it's usually, like, on average it's about 5 years after diagnosis, and just because that's the average doesn't mean that most people get started on insulin about 5 years after diagnosis.
Hmm.
Most of the time people, you got to have a couple of visits with your doctor with an A1C above 8, and they've exhausted every single oral medication before they go to insulin. Um, so usually the blood sugars have been high for a really long time, and it's harder also to convince if somebody's got a 7.9 A1C. And then your doctor's like, let's start insulin. Most people are going to push back on that, understandably so. Um,
Why do you think they wait so long to administer insulin?
Yeah, people are afraid of needles a lot. They see insulin as a failure, when
Hmm.
we have talked many times how insulin and other medications are not a failure. They're just another tool, they're the scaffolding.
Hmm.
And sometimes early insulin, the reason that that's pushed for is because it can really protect the beta cells
Yeah,
and
keep the
improve the
remaining
long
stuff from
term.
burning out. Yeah.
Exactly, because as we've spoken before, insulin and carbohydrate intake should match. Should that
Hmm.
word, like you want to take the insulin about 15 to 20 minutes before you eat, because the insulin action, if you read the prescribing information, I always call it the little mini newspaper that comes, that nobody, once you get about our age or older, the the 8-point font is really challenging to read. And people laugh when I'm like, have you ever read that little newspaper that comes with your insulin? They're like, you must be joking, right? And I
Yeah.
pull it.
Yeah.
It's hilarious because you pull
Let
it
me,
out and it's like, 4 foot wide by 2 foot high.
let me
And it
break out
always,
my 1950s microfiche machine so that I
yes.
can scan around here and
Yeah,
backlight
especially
it
if you
so
have
I can
a
actually read the
magnifying
thing. Yeah.
glass. Here is very microfiche-ish. Microfiche-ish. There. Anyway, yeah, so you're looking, but if you look at the mechanism of action of insulin, your Novolog is going to tell you 18 minutes is the time before it even starts to work. Carbohydrate digestion begins in the mouth, so that the carbohydrate ingestion is going to have the sugars raised in about 10 minutes. So if you've got the sugars raised in 10 minutes and you have an insulin that doesn't work for 18 minutes and you take it 18 minutes
Yeah.
after you eat,
You're
you're
18 minutes
behind.
too late. Yeah.
More than that, even. Yeah,
Yeah.
absolutely. So it's that mismatch because the timing is there. And this is why you want your pancreatic beta cells to still work, because
Yeah.
they notice the mismatch and they're like, oh, we need insulin. So your pancreas can release the insulin that you need to make up for the difference in the insulin dose that you gave.
And
And yeah.
spelling it out a little more, protecting those existing beta cells is the only thing that is going to allow you to
Mhm. I know where you're
ultimately,
going.
if
Hmm.
there's any chance of reducing or eliminating the medication,
Yeah,
you can't do that without beta cells.
exactly.
If you have tanked your pancreas to the point where you have like little to no beta cell function, you're gonna be on medication forever. That's just kind of that's the reality of the situation. So, I'd really just like to kind of echo what you said there. Early identification and appropriate administration of these medications is absolutely critical to hanging on to whatever beta cell function you have left.
Yeah. The key is start early, start slow, titrate really slowly because you can always build on later, and really know what you're doing, and be safe about it and having good conversations with your provider about it. Like, that is so crucial. We, like, recently we've worked with someone who has gone from 72 units of insulin and then she's down to 16 units
Oh wow.
and was going into the 40s and 50s overnight. So I said, you need to call your doctor's office now and talk about that dose of long acting insulin that you're on. So she eliminated her rapid acting insulin. You need to talk about that dose of long acting insulin because you're having severe hypoglycemia, severe lows in the middle of the night. She talked to her doctor about it, even though her A1C at the last visit was 6.8. The doctor was out of fear, told her to stay where she was. And that's the challenging part as an educator, as a facilitator of knowledge, and really trying to help the conversation between the doctor and the patient. Is that is a dangerous spot for her to be in. Low blood sugars overnight, especially severe low blood sugars. So anything under 50 would be considered a more severe low blood sugar reaction. Very likely her insulin needs to be backed off. So I really pushed for her to have another comment, like call your doctor again. Like, it is okay for you to fight for yourself, and you have more power to fight for yourself when you understand how insulin works, and you understand what's normal, and you understand what is not normal, and you understand when you're at risk for certain things. So
But if I
yeah.
if I can kind of read between the lines, what you're saying is that by successfully administrating the lifestyle changes that enable you to come off the medication, one should expect, and one's physician should expect, to have to reel back these medications, specifically the insulin, because what we're seeing in this one particular person is that her body is starting to perform like normal. Because if a normal body is taking extra insulin, you would expect a negative reaction. You would expect to have these lows. Is that
Yeah.
fairly accurate? Okay.
Absolutely. And she's walking, she's eating
Yeah.
tons of fruits and vegetables, especially non-starchy vegetables. She has an active job now. She's doing all of the right things and has already come from 72 units to where she is. So, unfortunately for her, her doctor is not used to that conversation. Her doctor is not used to the story being,
I don't think any
I'm
doctor's used to
coming
that
off.
conversation. It usually
Yeah.
goes the other way.
Yeah. So that's why you have to advocate for, another reason why you have to advocate for yourself. But going low is, if you have type 2 diabetes and
Hmm.
your biggest problem is insulin resistance, going low is not that big of an issue. I remember earlier in my diabetes education journey, somebody who was on 150 units of long acting insulin a day, and she took 50 units of rapid acting insulin before every meal. And before supper, I learned that she was having a steak and a salad before supper because she was afraid to have carbohydrate foods that would cause her sugar to go high at dinner. And so she's having
Hmm.
50 units of insulin, a huge amount of insulin. Like, people who have type 1
Wait,
diabetes often
hold,
don't take 50 units
yeah,
in a full
you
day.
you just you just told us that that's like the whole basal insulin for
Yeah,
the entire day.
the
Again,
basal and bolus
I
for
don't
the
understand
entire
a
day.
lot, but the numbers stick, and yeah,
Yes.
that's a whole day's worth at every meal. Is that
Yeah, I
right?
mean,
Golly,
people who have severe insulin resistance may need a unit per kilogram of body weight per or more. So for me, being 65 kilograms, that would be 65 units of insulin for me, and that would kill me dead if I took 65
yeah.
units of even a basal insulin. I'd have to live at the all you can eat buffet and like make myself sick trying to eat to support that amount of insulin. But yeah, for her, so I was really scared for her taking 50 units and I don't recommend anyone do
Hmm.
this, honestly, but she took 50 units, no carbs at all, but she was absolutely fine. She did not have a low blood sugar reaction because she was so resistant to
Hmm.
insulin that she was safe even taking these mega doses of insulin. So Of course, insulin can cause low blood sugar reactions. It can be very dangerous, especially in people who are super sensitive to insulin, like people with type 1. This is also why people who have type 1, it's more dangerous for them to, you think most people who interact in the medical field with people with diabetes, it's type 2, because that's 90 to 95% of all people with diabetes. So if 90 to 95% of the people you come across with diabetes can take a large amount of insulin and not have a low blood sugar reaction, then you get that 5% that are super sensitive. It can put that person with type 1 at risk because they're on the same sliding scale as someone who has type 2 diabetes, when maybe 1 unit of insulin lowers their blood sugar 150 blood sugar points. So if they're 150, 151 on that sliding scale and they get 1 unit, that could take their blood sugar to 0. So that's how it can be really dangerous. Now, of course, it wouldn't go to 0 because you have a liver, and the liver is very protective against hypoglycemia. The liver can dump out sugar when it knows it needs it. When the blood sugar levels in the blood are too low, it can put out glucose. But the modern insulins really keep people from having these really severe lows. Yeah.
So I think at this point in time we've established that sliding scale is at a minimum complex, or it
Yeah.
has a you have there's a lot that goes into getting good at successfully administrating it.
Mm-hmm.
Is there a better plan? Is there a better strategy for managing the blood sugars?
Yeah. Yeah. That's going to be simple in concept and really powerful when you put it into practice.
Mm-hmm.
And you really want to move from the reactive sliding scale coverage to a more proactive way of dosing insulin. So, what that means specifically is you keep your baseline basal background, Basaglar, Toujeo, Tresiba, Lantus. You keep those focused on just the fasting control only. Like, and you can also, you can study this. You can, in the morning time, or actually, if you took your breakfast meal, if you didn't feel really hungry for lunch, you could skip that lunch dose and really look at what the blood sugar does in between, after the 2 hours post breakfast to the pre supper, and really see how that basal insulin is doing. You could look at overnight blood sugars and see what they do. If your overnight goes from 300 down to 100, you're probably on too much basal insulin, and it might be time to have a conversation with your doctor about adding in a bolus insulin to that, the Humalog, Novolog,
Mm-hmm.
Fios, Bloomjev, one of those. And so you want to add a mealtime bolus for the carbs you're actually eating. So if you're a horrible carb counter, even better than sliding scale would be set dose. So typically you would need 50% of insulin to go to the baseline coverage and 50% to the mealtime. So if you needed 50 units of insulin a day total, let's say that would be 25 of Lantus, and then 25 divided by 3 meals a day. So maybe like 7 units each meal, 8 units, something like that. So you might have like small, medium, and large, where you have 6, 7, 8. So that will just give you more steady insulin, because most of
Mm-hmm.
the time people's total daily insulin needs are pretty stagnant. It's not like, and I've seen people take 120 units one day and 70 units the next day, and 120, and yeah, maybe that's because you didn't eat any carbs one day, but in general, you need about the same amount of insulin day in and day out. You typically need, your needs don't change too much. So the
So
foundation is really basal bolus therapy, and it works.
to me, it sounds like really just in time delivery.
Mm,
Really getting yourself to know exactly what's going in the mouth to be
as
able
best you
to
can.
deliver really exactly as much insulin when you need it. I don't know if it's appropriate in this context. How do lifestyle interventions jive with all this? I know you talked a little bit about Our Lady who had implemented lifestyle And just due to the fact we talked about it on our muscle insulin resistance episode, where, that 80% of that blood sugar can be soaked up by my muscles
Absolutely.
at any time.
You
So
just said it.
it, if
You
I
just said
am,
it.
if I am, let me just be incredibly explicit, walking after meals. If I am walking after meals, I'm just siphoning sugar out of my bloodstream and into my
Yep.
muscles. That really kind of eliminates the need for a lot of that insulin in the first place. And if I do not modify the dosage of exogenous insulin, I'm going to see problems because at nowhere in there is the math that, oh, we're immediately pulling that right out the bloodstream and storing it for instantaneous use in the
Yeah.
muscles.
Yeah, and anybody with type 1 diabetes will tell you if their sugar is high after a meal, they know that they can go for a walk and get it under control. And that's good and bad because sometimes people are just killing themselves walking after meals, trying to keep the blood sugar under control, not eating any carbs at all, trying to get no rise in blood sugar whatsoever. So it's kind of you have to be careful because there are, of course, you could go too far in one direction or the other. But yeah, there's an interesting doing this for as long as I have. You hear so many stories, and I remember I've talked to a lot of people who have type 1 diabetes, and you hear stories about, among the stories of people having to boil needles
Mm-hmm.
and pee on test strips to know kind of what range their sugar is in. You don't get an
Right.
exact, and it was just hilarious to me because I've had the pleasure of talking to people who used to have to pee on strips to get some kind of a range versus people now who are upset that their continuous glucose monitor doesn't exactly match their finger stick whole blood sugar number. And it's like the technology has advanced. And but the story I was trying to say is this gentleman with type 1 was telling me how before he was diagnosed, he loved running. Like anytime he felt bad or felt low energy, he
Mm-hmm.
would just take off out the door running, and he would run and run and run and run, and he would feel so good running. And this is before they really could recognize type 1 as quickly as they do now, and before it was diagnosed. And I just think that's so interesting. Like, even in type 1 diabetes, where you have to have insulin, he would see major benefit from movement and the muscle's ability to take in glucose in the absence of insulin.
That was his unconscious soothing strategy for
Right.
for what his
Yeah, the
for
body
the chaos
is.
going on the side. Yeah.
The body is really remarkable in that way, is that oftentimes you'll see people doing things, and I see people who have type 1, like that's a 6, that's a 5, like they just kind of intuitively know, and most of the time it works. But a lot of times, because there's so many different factors, 42
Mm-hmm.
different factors coming into play, that it's not always right. And then that's when you get the wind taken out of your sails, you get your feet knocked out from under you.
So how do we start normalizing? Let's just call it post meal movement bolus, right? We talked about taking bolus insulin before a meal. How do we, as a society, normalize the expectation that movement after a meal is a just very healthy practice for pretty much everybody, certainly all adults.
Just Nike slogan. Nike, if you want to sponsor us, we're up for that. Just
just
do it.
just move it. Is that what we're?
Yeah, you've got to move it, move it. Yeah.
Yeah, there you go.
I
There you
would
go.
say, okay, I would, so at the, normally we do like okay, what can you do differently because
Hmm.
you listen to this podcast? So I would
Yeah.
say,
What's the takeaway for this week, Amber?
yeah, for the next week, for the next 7 days, if you
Hmm.
are already taking mealtime insulin, really focus on giving it before, like 15 to 20 minutes before your first bite, and see if you notice a difference. I guarantee you will. I would be shocked if you didn't notice a difference giving it 15 to 20 minutes before your first bite. And then the time to check to see how that worked is at that 2 hour post meal. So first bite of food is at 12, 2 hours is when you note what the blood sugar is, whether you just kind of look at your CGM and see where that is, or you do a finger stick. But really notice the difference in how steady you feel, not just the blood sugar numbers, but your energy levels, how you feel from not being yanked down and thrown up, in your blood sugar levels. And if you're still on a sliding scale or just on basal, talk with your healthcare provider about whether, especially if you notice you're going from 300 to 100 overnight, or if you're tanking in between meals. Here's the thing. If you're noticing that you have to feed insulin, in other words, if you're noticing you have to eat to keep from going low, because how are you supposed to, if the goal is to lose about 10% of your body weight to really help with insulin resistance, how are you supposed to do that if you're feeding insulin when you're not hungry? That's a big one. So really talk to your healthcare provider about if adding just one mealtime dose to your biggest carbohydrate meal could help you move forward, and then maybe two. But yeah, the complexity and the burden of shots, if you're doing 3 times a day before meals plus a long acting, you just went from 1 shot a day to 4. And a lot
Yeah.
of people are like, heck to the nah. Like that is not, but just let that motivate you to do the movement post
Yeah.
meal, to do the
Yeah.
changes that you need to not ever have to be in this situation again. If you have the blessing, and I hate to, forgive me to say that, but people who have type 1 would agree with me. If you have the blessing of being able to not be on insulin, use that as a motivator to
Yeah.
get off of it for good.
If there
I
if there is a chance, if there is a chance for healing, if there is a chance to reverse the devastating effects of this chronic disease, guys, jump on that. Jump on that right now. The movement after meals works. It is ridiculous how well it works. And even 2 to 5 minutes, like 2 to 5 minutes is meaningful, right? Obviously build on that, but 2 to 5 minutes after meals, we're gonna beat this drum until until everybody knows. After the meals, you do the walk and just watch what happens to those blood sugars. You will be amazed at how quickly they drop off there. All right, Amber, this one's been really good. This is one that I did not really know a lot about, and even I, not not being insulin dependent, um, I feel a lot more competent to maybe ask better questions.
good,
You know,
because it's challenging to make this interesting and make it relevant, because everybody is different. Everybody has different insulin schedules, and there's even really concentrated insulins and older insulins like Humulin or Novolin N and
hmm
R. Um, by the way, if you're ever in a financial, real tough spot financially, if you have type 1 and you have to have insulin, but your doctor's office, and this, sorry, not to get off on too crazy of a thing, but I really want to just touch on this really fast. Like, a lot of endocrinology offices are booked out, 4 to 6 months. And sometimes you've got an appointment and then it gets bumped because the provider's out that day, and then the next appointment might get bumped because your work is like, no, you can't have off, you have to come in. And then before you know it, the doctor's office is like, no, we won't prescribe your insulin until you come in for an appointment, and you're totally out. If you find yourself in that predicament, just know that you can get from Walmart, potentially other places, but I know from Walmart you can get Humulin R or Novolin R over the counter without a prescription for about $25, $35, somewhere in there. I think 35. But if you have to have insulin, if your life depends on insulin, as it will with type 1 diabetes, if you've got to have it, that's one resource that I want to spread far and wide, that you can get Humulin R or Novolin R over the counter without a prescription for $35, give or take.
Okay. Good to know.
That was
All
a
right.
terrible aside, but I wanted to put that out there.
Hey, no, we created this podcast to get the information out there. There is a tremendous need to heal and a tremendous opportunity for healing. So, yeah, don't ever regret putting more out there. There's a need for it. So, this has been yet again another episode of the Diabetes Podcast. We will talk to you all
Thank you
next
for
week.
joining us.
Thanks for tuning in to the Diabetes Podcast. If you found this episode helpful, share it, leave a review, and subscribe so you don't miss what's coming next. And if you got questions, send them our way at support@empowereddiabetes.com. We'd love to feature them in a future episode. Until next time, take courage. You can do this, and we can help.